But usually the multidisciplinary conference is where all specialties come together to brainstorm on a particular case in a view to arrive at a final diagnosis. The case has been unraveled already, but the admin of the assembly has done it in such a way that he is not going to tell you the final diagnosis until we all have been able to brainstorm on that particular case. So these are the rules of engagement. Dr. Jimoh Nasir is going to be presenting the case. He's going to tell us his differential diagnosis, why he's going with those differential diagnoses, the strong positives, the strong negatives, and he's also going to tell us what his final diagnosis is, after which I'm going to open the floor for the participants to also tell me what they feel is the likely diagnosis. I'm going to record all those likely diagnoses, and then at the end, we are going to hear the verdict. That is the final diagnosis from the admin of the assembly. So I want you to please listen attentively and follow the case. I've sent a copy of the case file to the assembly page. If you don't have it, I'm going to send it again so that you can go through and also participate in this particular discussion. Finally, there is prize. We have prizes to be won by anyone who can clinch the diagnosis apart from the presenter. So I wish you all the best. And then I'm going to allow Dr. Nasir now to unmute his mic. Very beautiful. You can share your screen now.
Good evening, the admin of the Doctors' Assembly and other honorable members of the Assembly. I am Jimoh Nasir, and I will be taking the multidisciplinary conference for today's virtual assembly. So I will be starting by taking the case presentation of a 6-month-old boy that was seen in the emergency department of this hospital because of gastrointestinal bleeding and abdominal pain. The patient had been in his usual state of health until 2 days before presentation, when his parents noted that he began to have intermittent episodes of abdominal pain. During these episodes, some of which woke the patient from sleep, he cried and pulled his legs up towards his chest while lying on his back. His parents reported that they palpated his abdomen during some of the episodes, and it felt rigid. They suspected that he might be having discomfort related to excessive intestinal gas. He continued to eat and drink normally without vomiting. The next day, the patient had 2 bowel movements, and the stools had reddish discoloration. With the first bowel movement, the redness seemed to be present in a small amount and only on the outside of the stool. With the second bowel movement, the amount of redness increased. The patient mother attributed the stool discoloration to beet consumption, since bowel movement with reddish stools had also occurred in the past after the patient had eaten beets. Intermittent episodes of apparent abdominal pain continued, and between the episodes, the patient behaved normally. On the morning of presentation, he had a 3rd bowel movement with reddish stools. His parents took him to daycare, where he continued to have occasional periods of crying and pain, followed by a bowel movement that appeared to consist almost entirely of blood, including a large clot. After this bowel movement, he was reportedly pale and diaphoretic. The daycare provider called the patient's mother, who picked him up and took him to the emergency department of another hospital. On examination at the other hospital, the temperature was 36.5 degrees Celsius, the pulse was 178 beats per minute. The blood pressure was 95/52 millimeters of mercury. The respiratory rate was 24 breaths per minute, and the saturation was 100% while the patient was breathing ambient air. The weight was 9.1 kilograms. On palpation of the abdomen, there was diffuse tenderness, which was greater on the right side than on the left, and there were no masses palpable. There were no external anal fissures, and the remainder of the physical examination was normal. 2 hours after arrival at the other hospital, the patient passed a dark red stool that was described as resembling currant jelly. Intravenous normal saline, 5 ml per kilogram, was administered and was brought by ambulance to the emergency department of this hospital for further evaluation and treatment. The patient had a history of infantile coli and gastroesophageal reflux, which had previously been treated with ranitidine. He received a low lactose cow milk-based formula. Pureed fruits and vegetables had recently been introduced into his diet, after which constipation developed. His stools became more firm, and daily bowel movements were associated with straining. He received cholecalciferol, and he had begun using unspecified over-the-counter teething gel and unspecified homeopathic teething tablets 1 week earlier. Immunizations were current to 4 months of age. Vaccines, including the second dose of live oral human bovine Isotam pentavalent rotavirus vaccine, had been administered 6 weeks earlier. There were no known allergies. The patient lived with his parents, attended daycare, and had no known sick contact. His parents were from Brazil. He was born in the United States and had not traveled outside the country. There was no family history of bleeding disorders. On examination, the temperature was 36.3 degrees Celsius. The pulse was 160 beats per minute. The blood pressure was 98 over 47 millimeters of mercury. The respiratory rate was 32 breaths per minute, and the saturation was 99%, while the patient was breathing ambient air. He appeared well. Bowel sounds were present. The abdominal examination was otherwise limited because the patient was crying. The diaphragm contained melanas and a small amount of stool. The remainder of the examination was normal. 35 minutes after the patient arrived at the emergency department, an ultrasound examination of the abdomen was performed. There was no evidence of intussusception, appendicitis, or a focal lesion or abnormally dilated bowel loops. Bowel peristalsis was present. On examination after ultrasonography, the pulse was 168 beats per minute and the blood pressure 94/36 of mercury. The patient appeared pale. The abdomen was soft without distension, tenderness, or masses, and bowel sounds were present. Results of physical examination were otherwise unchanged. Blood levels of erythrocytes, glucose, aspartate aminotransferase, alanine aminotransferase, alkaline phosphatase, total bilirubin, direct bilirubin, and C-reactive protein were normal, as were the anion gap, platelet count, red cell indices, and results of renal function tests. The results of other laboratory tests are shown in the table below. PAC cells were transfused, and pantoprazole and famotidine were administered intravenously. A diagnosis was made. So this is the table showing the results of hematology results. Of note is the reduced red cell count and elevated white cell count of 22,200 cells per meter cube. So from the foregoing, it is necessary to extract some important points that should help us in arriving at a diagnosis. Some of the points extracted: at the age of patient 6 months, the history of hematochezia here. There's intermittent abdominal pain, although the pain is more on the right side of the abdomen. The patient is pale and has well tachycardic. There was no vomiting, no fever, and no masses. These extractions, I believe, will help us in streamlining many distractions in the case presentation. So some distractions are low lactose diet, pure food consumption, cholecalciferol administration, and homeopathic teething mixtures. All these, I believe, are distractions, because if the patient takes low lactose diet, the implication is that probably the child has been having diarrhea or infantile colic in the past. So one of those things parents do, particularly in developed world, is to make the diet, the lactose in infant diet, to reduce the quantity of lactose in infant diet. So that's the reason the patient is properly taking low lactose diet. Fluid food consumptions. This is also done in Western world. Some parents do believe that when their child is transiting from taking predominantly breast milk, when they want to transit to taking solid food, they thought it wise in their own thinking to get some mashed vegetables and fruits as a semi-solid in preparing the child to transit fully to solid food. This is commonly done in the Western world. However, researchers are now showing that this action or this kind of diet actually causes constipation and some other chewing difficulties and disorders in children. So this action is being discouraged. However, the underlying thing with this consumption is that it causes constipation. It causes constipation. Cholecalciferol administration is used by some parents to manage constipation and infantile colics. And homeopathic teething mixtures has also been shown to cause constipation. So all these distractions are just ways of managing constipation or are actions that actually cause constipation. So these, I believe, are some distractions. So in coming down to the summary of everything, essentially what we have with us is a 6-month-old male infant with lower gastrointestinal bleeding and associated intermittent abdominal pain. In other words, a colicky pain. Yes, lower gastrointestinal bleeding. I may not be too emphatic or too sure that the bleeding is lower gastrointestinal bleeding. However, as they say, common thing occur commonly. The stool is essentially hematochezia. Some episode of the stool, blood is seen at the outside of the stool. All these are possible pointer to a lower gastrointestinal bleeding. However, if an upper gastrointestinal bleeding is torrential and substantial, it can also present with these qualities. Be that as it may, most likely thing is that what we have with us is a lower gastrointestinal bleeding in a 6-month-old male infant associated with colicky intermittent abdominal pain. So from this summary, we then try and assess the causes of lower gastrointestinal bleeding associated with intermittent abdominal pain. And we try as much as possible to rule them out one after the other. So based on this, I have the following differentials. I have symptomatic Merkel's diverticulum. This differential are arranged in order of strength and importance to me. So the first is symptomatic Merkel's diverticulum, symptomatic gastrointestinal duplication, bleeding peptic ulcer disease, intestinal polyps, inflammatory bowel disease, especially ulcerative colitis, and other cause of lower gastrointestinal bleeding like anal fissures, hemorrhoids, intussusception, and others. So starting with Merkel's diverticulum. So some positive from the case report, case presentation in support of Merkel's diverticulum include: one, Merkel's diverticulum is a known cause of substantial acute lower gastrointestinal bleeding in the pediatric population. The age of onset of Merkel's diverticulum is, in most of the time, in pediatric population, less than 2 years old. Our patient is 2 years. Besides this, most of these cases in this age group occur before the first year. So this patient is 6 months. So age-wise, epidemiologically, from the age perspective, this patient falls into this differential. Apart from this, males are known to come down with complications of Merkel's diverticulum than females. They come down 3 times more than females come down with the complication. And some of the complications, as it shall be explained during the slide that will come, include bleeding, obstruction, and infection of the diverticulum. So in terms of the age and the sex of the patient, it is likely to be Merkel's diverticulum. So why the rectal bleeding is painless is Merkel's diverticulum? Some patients present with severe episodes of abdominal pain before the onset of bleeding. Merkel's diverticulum actually has many varied presentations, and there's no presentation that is actually pathognomonic of Merkel's diverticulum. So in some instances, without any complication, as I said earlier, the patient will come, there will be abdominal pain that can confuse diagnosis before the bleeding even comes. Patient comes with abdominal pain, after which bleeding comes. So it's not unusual to have abdominal pain in patients with bleeding merkel diverticulum. But apart from this unusual presentation of abdominal pain coming before the bleeding, there are some instances or complications of merkel diverticulum that can on their own present with intermittent abdominal pain. Some of those complications include obstruction. This obstruction can come from, the obstruction can come, it will come with pain. I must say at this point that obstruction of merkel diverticulum is common in adults. However, reports and cases of obstruction has been seen in pediatric population. So the obstruction will also come with pain. So a pain in a tubular structure, an obstruction of a tubular structure comes with intermittent abdominal pain, as we have in this our index patient. Obstruction can also be caused by intussusception. Merkel diverticulum on its own can act as a lead point of intussusception. So all these constellations can actually come as pain in a bleeding merkel diverticulum. Apart from this, the diverticulum can also become inflamed. So when there's inflammation, there will be pain and the like. And don't let us forget that the white cell count in this patient is elevated. So an inflamed diverticulum, diverticulitis, can actually present with abdominal pain. However, in this instance, one will expect the patient to be febrile and be more sick, which is not the case in this patient. So it's not likely that the complication of merkel diverticulum here is from the diverticulitis. Another thing that can come as pain in merkel diverticulum that can cause a bleeding merkel diverticulum to be painful or to come with abdominal pain is foreign body, maybe from the food, and the patient has earlier been introduced to a purine diet, which is more or less like a semi-solid food. All this can actually block the lumen of the diverticulum. So this constellation can actually make the patient to present with abdominal pain. And who knows that the abdominal pain that this patient is having could be just a coincidental event occurring together with the bleeding merkel diverticulum. If you remember that this boy has been having infantile colic, there's history of infantile colic. So the colic has well be coming at the same time that the merkel diverticulum is bleeding. So from the foregoing, it is not out of place to have a complicated merkel diverticulum also coming with bleeding. The bleeding can be from the obstruction, from foreign body, or from other pathology, as said earlier, the infantile colic. Some things are, however, not in keeping with merkel diverticulum. Intermittent abdominal pain, straightforward merkel diverticulum, straightforward bleeding merkel diverticulum. The bleeding is painless rectal bleeding. So the intermittent abdominal pain is not in full support of a bleeding merkel diverticulum, although I made mention earlier of some reasons why a merkel diverticulum can cause pain. The patient temperature pattern has been normal. When we expect a patient with diverticulitis to have elevated temperature, the temperature pattern has been normal. Then elevated white cell count is also normal. Yes, a pure bleeding merkel diverticulum, one do not expect an elevated white cell count. But if there are complications, and most of those complications will cause fever and elevate the white cell count, that can happen. But in this case, a straightforward merkel diverticulum shouldn't come with elevated white cell count, shouldn't come, the temperature should be normal. But in this case, there is abdominal pain that one will expect the temperature to be high. So all in all, these are some of the negatives that may prevent one from making the diagnosis of merkel diverticulum. Another possibility is gastrointestinal duplication. Gastrointestinal duplication is essentially, or in terms of pathophysiology, more or less like a merkel diverticulum. A merkel diverticulum has an ectopic gastric tissue for most of the time. The same thing is happening in gastrointestinal duplication. So part of the normal gut has a duplicate. That's essentially what is happening in gastrointestinal duplication. Although it's a rare condition, but it's a cause of painless lower GI bleeding, because the duplicate can contain gastric mucosa that can bleed and cause perforation, that can cause ulceration of the mucosa. So this gastrointestinal duplication can be a cause of lower GI bleeding. And the presentation is usually before the age of 1. Our patient is 6 months old, so that is more in keeping with gastrointestinal duplication. Abdominal tenderness is also a feature of gastrointestinal duplication. The symptoms, the signs and symptoms seen in gastrointestinal duplication depends on the site of duplication. Can have duplication in the cervical region, thoracic region, gastric region, duodenal region, and all other parts of the gut. So a duplication of the gastrointestine of the stomach, a duplication of the stomach should cause ulceration, pain, and bleeding. Apart from this, as a negative now, most cases of gastrointestinal duplication, there will be palpable mass on the abdominal examination. In this case, there was no palpable mass whatsoever. Another negative is that the negative abdominal examination finding and the ultrasound, most time, ultrasound were able to pick some duplications in the gastrointestinal tract. The ultrasound our index patient did, there was no evidence of duplication. These are some of the negatives that are not in support of gastrointestinal duplication. Another differential is a bleeding peptic ulcer disease. Peptic ulcer disease is a rare cause, particularly the complicated peptic ulcer disease bleeding. It is rare in the pediatric population. However, if it occurs and the bleeding is massive, one can have passage of hematochezia and all other character of passage of blood per rectum that was seen in the case report. And let us keep in mind that this infant has an antecedent history of gastroesophageal reflux disease, for which he has been treated with histamine blockers. Although very rare in pediatric group, that's a negative, an important negative in this condition. Besides, there is a criteria, the dyspepsia criteria, set by pediatric gastroenterologists. This is a criteria that is used to assess if a child actually has symptoms of peptic ulcer disease before further evaluation will be done. Unfortunately, as a negative, this patient doesn't fit into the criteria. The criteria are major criteria and the minor criteria. The major criteria are recurrent epigastric abdominal pain and recurrent vomiting at least 3 times in a month. The epigastric pain in this patient is not recurrent, and there was no history of vomiting whatsoever. So none of the major criteria is fully adapted to this in this case. One need at least 2 major criteria, or a major criteria with 2 minor criteria, or a 4 minor criteria to be able to say that an infant or a pediatric patient has symptoms and signs of peptic ulcer disease. But the patient, our index patient, doesn't fulfill any of the criteria set down to assess peptic ulcer disease. Some of the minor criteria include association with meal. There's no association with meal in our patient, heartburn, regurgitation, nausea, excessive belching and hiccup, early satiety, periumbilical abdominal pain, and family history. So these patients do not fit into most of these criteria, and as such, bleeding peptic ulcer disease is a far differential in this case. Of note are intestinal polyps. So there are many polyps that can cause lower GI bleeding. Some of the polyps include juvenile polyps. Juvenile polyps is actually seen between 2 to 5 years of age, so it's not likely in our patients. It comes as a painless rectal bleeding. The bleeding in this patient is associated with an intermittent abdominal pain, although in about 10% of population, patients or children with juvenile polyps do have abdominal pain, but not classically intermittent as we have in this case. We also have juvenile polyposis syndrome. In this instance, there's rectal bleeding, occasional abdominal pain. But of note, as a negative, is that in this syndrome, there is diarrhea, and there's no report of diarrhea whatsoever in our case. What you have is constipation. So juvenile polyposis syndrome is also not likely. We also have lymphoid polyps or pseudopolyps. Lymphoid polyps is like inflammation, hyperplasia of submucosal lymphoid tissues in the rectum. So they come with rectal bleeding that can be occasionally torrential and rectal pain. The pain in lymphoid poly is associated with defecating. Our index patient doesn't have that kind of pain. What he has is a painless bleeding with an associated intermittent abdominal pain. So lymphoid poly is also far. Other kind of polyps are diffuse Jaeger syndrome. It's a kind of hematoma of muscularis mucosa. There's crampy abdominal pain. However, in this syndrome, the bleeding is scanty. The bleeding in this patient is a torrential bleeding that necessitated blood transfusion. Besides, there's mucocutaneous pigmentation in Creutzfeldt syndrome. This is not seen in our index case. Of note is also familial adenomatous polyposis. It's associated with rectal bleeding. The bleeding could be torrential. It's associated with abdominal pain. However, an important negative is diarrhea. This patient, our index patient, is constipated, so it's also not likely. Another likely differential is ulcerative colitis, inflammatory bowel disease. Ulcerative colitis, to be specific, is a cause of abdominal pain and rectal bleeding. However, ulcerative colitis is a chronic condition, and it is rare to have it before 2 years of age. Our patient is having an acute episode of rectal bleeding with abdominal pain. Ulcerative colitis, most of the time, the presentation is a chronic condition, and the age of presentation is most of the time above 2 years for patient in the pediatric age group. This patient is 6 months, and the bleeding and the presentation is acute. So in ulcerative colitis, what you have is diarrhea as opposed to constipation in our index patient. There may be fever. This patient is not febrile, and there will be extraintestinal manifestations. The patient, there's no any extraintestinal manifestation reported whatsoever in this patient, and inflammatory markers will be high. This patient, all the inflammatory markers, the few ones tested are low, the C-reactive protein, ferritin, and the likes. All the inflammatory markers are low. Besides, the bleeding in ulcerative colitis is not really torrential. So ulcerative colitis, though a differential, is a far differential. So coming to other differential, first of which is anal fissure. One of the character of the bleeding described in this case actually is like gives anal fissure a possible diagnosis, in that the patient is constipated. Most of the pediatric patients with constipation, some of them do have anal fissures. And the character of the blood described in the first episode of hematochezia, the blood was outside the stool. This same feature is seen in anal fissure. Important negative is that during the examination, there was no any anal abnormality, anal fissure detected. During the examination of this index patient, there's no anal abnormality. And the bleeding in anal fissure do not cause hemodynamic instability. So that makes an anal fissure an unlikely diagnosis. Other investigations include hemorrhage, our examination, physical examination has excluded hemorrhage. Intussusception. Yes, the patient had an episode of recurrence too, but it has been reported that some bleeding in symptomatic mercury diverticulum also come as red current. Besides this, our ultrasound that was done during the evaluation of the patient excluded intussusception. The only reason we may still be considering intussusception is if it's an intussusception that occur, then spontaneously reduced on its own before the ultrasound. But then we expect the patient to be vomiting, we expect to see a palpable abdominal mass, and the child should be sicker than this. All these are not there. So it makes a diagnosis of intussusception far. Other possible diagnosis is immunoglobulin vasculitis, that there is no scarring purpura. In this instance, there is abdominal pain is documented, there is bloody stool is documented. However, to make a diagnosis of immunoglobulin vasculitis, there must be skin manifestation. There will be palpable purpura that is more in the lower limb. There's no skin manifestation made whatsoever in this patient. So that diagnosis is also far. Of note is intestinal tuberculosis. Ileal tuberculosis has been shown to cause torrential bleeding that can cause hemodynamic instability, as we have in this patient. The bleeding is massive, is dark, and mixed with stool. However, and of note is also that the white cell count is also elevated in this patient. In tuberculosis, we expect an elevation in white blood cell count, particularly the lymphocyte line, which is not the case in this case. So intestinal TB is a diagnosis, but also far, because this patient has no contact with any sick person. This patient, the weight is normal. All other parameters are normal. So intestinal tuberculosis is a diagnosis, but a far diagnosis. So from the foregoing, based on the history of lower gastrointestinal bleeding, intermittent abdominal pain, and absence of intestinal obstruction, the more likely diagnosis is bleeding Merkel diverticulum for the reasons earlier highlighted. One, Merkel diverticulum, the bleeding Merkel diverticulum is associated with torrential lower gastrointestinal bleeding that cause hemodynamic instability, which we have in this patient. And then also it's of note also is that this patient was given ranitidine, was given famotidine, and pantoprazole during the case report. These drugs are used in managing acid peptic disease. So most likely an ectopic gastric tissue in the Merkel diverticulum is secreting and causing ulceration. That's the reason why they gave this. So putting all this together, the diagnosis is most likely a bleeding Merkel diverticulum, and it's likely inverted. Yes, inverted bleeding Merkel diverticulum has also been reported, in which the lumen of the diverticulum gets struck or gets invaginated. In this instance, there may be abdominal pain, as we see in this case, a tubular obstruction, so to say. So a bleeding Merkel diverticulum is most in keeping, and the pain can be explained by a likely inversion of the diverticulum. So to further workup, various studies can be done. This to outline the gastrointestinal tract, and a blind ending pouch may be seen. Sorry for that. A blind ending pouch may be seen. There's also a Merkel scan. It's actually a scintigraphy in which technetium 99 is used. This is just to highlight areas where we have gastric mucosa, and it has been used extensively in diagnosing a bleeding Merkel diverticulum, a diverticulum with a gastric mucosa. Abdominal CT scan will be important in diagnosing an invaginated or inverted Merkel diverticulum, capsule endoscopy, and the diagnosis can best be clinched by surgical exploration. Most of the times, history, examination, and even investigation do not reveal diagnosis until the patient is open up. So the best approach to management or to ascertaining the diagnosis is opting for surgery. This for diagnosis and also for treatment. So I guess that is my submission. We are awaiting the jury, the oracle, to give us what the diagnosis actually is. While awaiting the admin, I want to thank the admin for his support. I also want to thank the coordinator of Faculty of Surgery, Dr. Ridwan Adegboyega, all other faculty members, and the members of Doctors Assembly at large, and all other visitors to today's virtual assembly. Thank you very much.
Thank you so much, Dr. Jimoh Nasir. That is very explicit, and I don't know. Just as I've said, for those who have been part of the MD conference before, you will agree with me that sometimes a speaker can sound very convincing, and by the time we read the diagnosis, it might be something else. But I can tell you that it's obvious that Dr. Jimoh Nasir actually did an extensive work on this particular case to convince us, the listeners, that the answer is what it is. So now I'm going to open the floor for anyone who would like to either add, support, or go against Dr. Nasir's final diagnosis. Please feel free. before we now go to the final verdict of this particular case?
Adegboyega Gary one. I'd like to actually appreciate Dr. Jimoh Nasir. There's actually nothing to add, really. I agree 100% with the diagnosis. There's actually nothing to add, like I said earlier. But in terms of, should I say, presentation vis-a-vis the age group of the kids, this child is perhaps a case that was sorry, this case is a case that was reported in the white man's land. So it is known that the commonest presentation for a Merkel's diverticulum is bleeding. About 40 to 60% of patients with Merkel's diverticulum will present with bleeding. Another 25% can present with obstruction. That is as a result of the reasons highlighted earlier. It could be a focus for intussusception, which would cause intestinal obstruction. It could be that it is attached to the anterior abdominal wall through a fibrous cord, and that can twist on itself. So you can imagine having your finger pointing forward and then you curve it backward. So that is like how a Merkel's diverticulum is. So between the junction from your proximal phalanx and then distal phalanx, you can have a cord that attaches that junction to whatever you are pointing at. So there can be volvulus. There can also be persistent vitelline artery. That is a branch of the superior mesenteric artery where we could have volvulus leading to obstruction. Very rarely there could be parasites and foreign body obstructing that, causing obstruction. And just as a quick addition, remember that Merkel's diverticulum is just one of the presentations of anomaly of the omphallomesenteric duct or the vitelline duct, which refuses to obliterate after the 9th week of intrauterine life. So it is that part that connects the intestine to the yolk sac in the child. And so bleeding is the commonest, obstruction next, and then other things. But in older children, it is usually painless bleeding. In infants and in newborns, it usually presents as intestinal obstruction, usually intussusception. But in this case, we have both. Perhaps the child had intussusception, which was like the kind of the classical case he eventually presented with, and then maybe there was a relief of the intussusception or a volvulus, maybe twisting and untwisting. Yes, intussusception can spontaneously resolve, which could be the case in this child, or volvulus. And then what brought the child to the hospital was this massive bleeding. The take home is any child that has massive GI bleeding of unknown cause, Merkel's diverticulum should be entertained as a very strong differential. In fact, as number one differential. And the diagnosis of choice. I didn't say the best diagnosis now because Dr. Nasir also said it. The diagnosis of choice will be a Merkel scan, a technetium 99 scan, which is going to highlight any part of the gastric mucosa. So you usually see a kind of black pigmentation in the stomach because you have gastric mucosa there. And then you'd also see it in the ectopic site of the Merkel's diverticulum. It is usually a study you do over 1 hour. You can be having the shot every 5 minutes. And at the end of the day, you can even find those things in the kidneys and in the bladder because it has renal excretion. But you can also have a negative scintigraphy scan. And it does not necessarily rule out the fact that a Merkel's diverticulum exists. And that is why the best bet or the best way of diagnosing it is via laparotomy. You open up and then you see the Merkel's diverticulum and then you treat accordingly. Well, maybe I shouldn't bogus, but essentially the part that actually ulcerates is not even the diverticulum. It is the intestine, the part of the ileum where the diverticulum is attached. Because the diverticulum has gastric mucosa, it is usually lined by the 3 layers. You know, you have the mucosa, you have the submucosa, the muscle, and serous. So it is used to that environment. But the small intestine that is not adapted to gastric ulceration or acid production is the part that is actually ulcerated that leads to that bleeding. And you can just excise, we call it segmental recession of that part, and then you close up. So Dr. Nasir has done a wonderful job. He has also given reasons for the differentials that are also possible causes, and why we are not thinking of those before Merkel's diverticulum. And just in addition, you can also give H2 receptor blockers before you do your Merkel scan. It actually improves the sensitivity of the scan. So thank you, admin, for the opportunity, and Dr. Nasir, well done.
So I've been seeing chats, and Dr. Oluwengalabi. Okay. So he said some authors call Merkel diverticulitis as a left-sided appendicitis. Okay, we shall see. So in the absence of no other comments, I think we can proceed to read the verdict. So I'm going to be narrating the story of the doctor that reviewed this child, and I'll be using some terminologies that will sound as if I'm the one that actually reported the case. So that's the reason why I'm giving this particular caveat. So it's a case that is being reported by someone that we just decided to use it as our learning point tonight. So this 6-month-old boy presented with gastrointestinal bleeding manifested by hematochezia along with intermittent abdominal pain and one episode of melena. He appeared ill and had tachycardia. Pertinent features of the history include gastroesophageal reflux, a possible milk protein allergy since he was receiving a low lactose formula, and exposure to unspecified teething tablets and homeopathic teething medication. It is important to note that absence of fever, forceful vomiting, and then hematemesis. Please, we should note that because care in the emergency department is more process-driven than outcome-driven, the evaluation in this case can be condensed into the following steps: rapid assessment, stabilization, and diagnostic evaluation. So under the rapid assessment, this ill patient had tachycardia, he had pallor, profound anemia with ongoing blood loss, and intermittently abnormal findings on abdominal examination. He presented with gastrointestinal bleeding manifested by hematochezia and melena. My initial diagnostic consideration include causes of lower gastrointestinal bleeding, although the description of melena gives me reason to think that this patient could have been bleeding from upper and lower GI sources. Less likely is an isolated massive upper GI bleed with rapid transit time through the infant's gastrointestinal tract. Then in the aspect of stabilization, the patient's airway was intact and his breathing was unlabored. However, his circulation was compromised. He was pale and had tachycardia, and the hematocrit was 17.5% with ongoing blood loss. He required volume resuscitation with administration of isotonic fluids and the transfusion of packed red cells, which was performed in the emergency department. The patient was neurologically intact. A bedside glucose measurement may have been useful in determining whether poor feeding with resultant hypoglycemia contributed to his unwell appearance. The reported use of homeopathic and unspecified teething medications raises concern about unintentional toxic exposure. Could the teething tablets or medication have contained acetaminophen, which can cause an overdose that leads to liver failure and gastrointestinal bleeding? Or could the teething tablet contain NSAIDs, which can cause irritation of the gastric mucosa and subsequent gastrointestinal bleeding? Although these exposures are unlikely underlying causes of this patient's illness, They warrant further consideration and possibly toxicologic testing. Now, my diagnostic evaluation falls under 3 broad categories: common, less common, and potentially life-threatening. The common ones include ileocolic intussusception, Merkel's diverticulum, allergic gastritis and colitis, infective colitis, fissures, and polyps. The less common ones include vascular malformation of the GI, atypical lymphonodular hyperplasia, hemolytic uremic syndrome, inflammatory bowel disease, toxin-mediated processes, and bleeding diathesis. The life-threatening ones include a perforated viscous, acute abdomen, septic shock, and upper GI bleed. Among the common diagnoses, ileocolic intussusception seems to be the most likely possibility. The patient presented at a typical age, since intussusception most likely occurred during infancy or early childhood, and had colicky abdominal pain and worsening GI bleeding, with stool described as resembling currant jelly. Merkel's diverticulum is the most common congenital malformation of the gastrointestinal tract, and if the diverticulum contains ectopic or heterotopic mucosa, it can cause gastrointestinal bleeding. Of the clinical findings associated with Merkel's diverticulum, bleeding is one of the most common in children, just as Dr. Nasir has rightly stated. Since Merkel's diverticulum is classically associated with painless bleeding, this patient's apparent abdominal pain is difficult to reconcile with this diagnosis. However, if Merkel's diverticulum is associated with obstruction caused by intussusception, volvulus, or perforation, then pain can be a complicating feature. I would also consider an inflammatory or allergic gastritis or colitis, because these are common causes of lower gastrointestinal bleeding among children who present to the emergency department. The presence of mild gastritis plus colitis related to a milk protein allergy could explain both the hematochezia and melena, mixed upper and lower gastrointestinal bleeding, so to say, as well as the associated pain. Infectious colitis seems unlikely, given the absence of fever, the absence of sick contacts, and also the child has not traveled outside the US since he was born. Other common causes of lower gastrointestinal bleeding, such as fissures or polyp, are not typically associated with such a severe presentation. So these diagnoses are easily ruled out in this case. So in a 6-month-old infant, the less common diagnoses that cause lower GI bleeding include vascular malformation of the gastrointestinal tract, and so on, just as I've listed earlier in my deposition. Now, I will give these uncommon causes careful consideration only after the common causes have been adequately ruled out. In this case, several diagnoses must be considered because they are potentially life-threatening if missed. These diagnoses can be consequences of either the common or less common conditions, and they include perforated viscous, acute abdomen, obstruction, hemorrhagic shock, septic shock, the presence of associated upper GI bleeding while the patient is being evaluated for lower GI bleed. Serial physical examination and diagnostic testing are critical in identifying any of these potentially life-threatening processes. The findings ascertained through diagnostic testing are the most important in developing a differential diagnosis in this case. Hematocrit of 17.5%, elevated white blood cell count of 22,200 per cubic millimeter, which is non-specific but is a worrisome finding, and the absence of intussusception and other notable findings on ultrasonography. The normal electrolyte level, liver profile, coagulation indexes are reassuring, and they argue against some systemic disease processes that would typically be associated with abnormalities in one or more of these measures. However, A few additional studies would help to narrow the differential diagnosis because of the possibility of a toxic exposure. I would perform a toxicology screen. In addition, I will perform a blood and stool culture to evaluate for infection, as well as abdominal radiography to assess for bowel perforation, given the multiple days of gastrointestinal symptom and the worsening clinical appearance. To rule out upper gastrointestinal bleeding, I will consider performing a gastric aspiration in view of the available test results, the absence of intussusception on abdominal ultrasonography, and the patient's ongoing blood loss. Two diagnoses from my list of common diagnoses remain most likely: Merkel's diverticulum and gastritis plus allergic colitis. Many other diagnoses have been effectively ruled out through diagnostic testing, and several less common causes would not be seriously considered until these two that I've mentioned above have been adequately dealt with. In addition, I'm worried about the possibility of potentially life-threatening hemorrhagic shock, given the patient's continued blood loss and profound anemia. In the emergency department, we place emphasis on providing the best possible systemic care during the period leading up to the diagnosis rather than conclusively determining the diagnosis. In an infant who has massive lower GI bleeding with resultant hemodynamic compromise, and for whom intussusception has been ruled out on the basis of ultrasonographic finding, the most likely diagnosis is Merkel's diverticulum, and this possibility needs to be investigated before that diagnosis can be considered. The abdominal pain is one aspect of this patient clinical presentation that does not totally fit with the diagnosis of Merkel's diverticulum, although an obstruction or perforation could introduce pain into the clinical picture. The description of melena is not consistent with Merkel's diverticulum, but could be explained if the bleeding mucosa from the diverticulum was proximal enough for resultant blood to undergo partial digestion. It is also possible that the single stool described by the parents as melena was not truly melena, but stool with darker or maroon blood that originated from a lower rather than an upper GI source. My second most likely diagnosis, which is mixed gastritis and colitis, is less likely than Merkel's diverticulum overall, and bleeding related to allergic GI disease is unlikely to be as acute and to be as severe as the bleeding that we have seen in this index case. In the emergency department, it is more straightforward to obtain a scan to assess for Merkel's diverticulum than to perform an upper or lower GI endoscopy. The scan helps at least requires fewer hospital resources and does not require the administration of anesthesia to the patient, and it is non-invasive. So if a scan were non-diagnostic, I will consider other studies such as endoscopy or abdominal computed tomography, just as Dr. Nasir has said. So a consult was written to the pediatric gastroenterologist and the pediatric surgeons to see these particular patients, and these are their findings. So the first step by the gastroenterologist was to localize the source of blood loss. Melena is classically thought to reflect upper GI bleeding proximal to the ligament of Treitz, but it can also be caused by more distal lesions, such as lesion in the small bowel and the right colon. We considered both upper GI sources, which include variceal bleeding, vascular malformation, and ulcer, and lower GI sources, which includes colitis, Merkel's diverticulum, and vascular malformations. We thought that the subacute tempo of these patients, clinical presentation, the large volume of blood loss, and his age were most consistent with Merkel's diverticulum, although Merkel's diverticulum is commonly thought to be a painless lesion Pain can result from intussusception, where the diverticulum is serving as a lead point, intermittent volvulus and associated fibrous bands, or torsion. We recommended that the patient undergo prompt evaluation by a pediatric surgeon and that a scan to assess for Merkel's diverticulum be obtained after the administration of a histamine receptor antagonist to help retain radiotracer in the gastric mucosa. Now, the gastroenterologist thought endoscopy will not be immediately useful, although the performance of upper GI endoscopy is standard for a large volume of blood loss because of its potential for diagnostic and therapeutic intervention. Most causes of lower GI bleeding does not require colonoscopy. Furthermore, colonoscopy in a patient with severe acute bleeding may be technically challenging because of the difficulty with visualization. So the patient was sent to the radiology department to have this technetium 99 metastable paternity scan done. And I'm going to shed a little light on this because this is my own specialty. So the way this is done is that the H2 antagonist that was administered to the patient was actually to delay the transit of this particular radio tracer. Is a radioactive isotope. It has a particular half-life, and then after some times it degenerates, let me put it like that, and releases some radiations that is being picked by a gamma camera. Now, after the patient has been given, the patient will be observed for over 1 hour. Now, the radio tracer has affinity for gastric mucosa. So it will first of all go to the stomach. And this is the stomach of the patient. This is the stomach here. Now, the essence of the H2 histamine H2 antagonist is to delay the movement of this particular radio tracer from the stomach into the bowel loops. Because if that happens, it's going to obscure whatever we want to see. So now, let's have a look at what happens in the 5 minutes, 10 minutes. Now, look at this region. You can just follow my cursor, and you see that as we are going on, the blackness, let me put it like that, but we call it intensity, of this particular area becomes increasingly more prominent as we move towards the timeline. You can see the arrow. It becomes more prominent. While the one in the stomach still remains in the stomach. So that means there is a particular focus in that particular place that contains a gastric tissue that is actually taking up that technetium 99 metastable. So this is the urinary bladder. Now, another thing I want us to note in this particular study is the route of excretion of this radio tracer is actually through the kidneys. So the kidneys too and the urinary bladder will be seen to take up this particular radio tracer. Now, in this particular case, you might want to ask that, can't this be one of the ureter or one of the kidneys? Yes, it can. And that is the reason why the lateral was requested for. Now, the kidneys are retroperitoneal structures. They're expected to be around this particular region. But that structure that we have been seeing is still more anterior, which further reiterates the fact that this thing is a bowel-based lesion and it contains a gastric mucosa. Now, the pediatric surgeons were invited to review, and from their review, they decided that they are going to open up this particular patient, and the patient was taken to the operating room, where a short transverse incision was made in the right lower quadrant and the diverticulum was identified. Inflammation and scarring was present at its base. These findings are consistent with ulceration in the small intestine. as its junction with the diverticulum. A segmental small bowel resection, which included the diverticulum and the presumed area of ulceration, was performed, followed by a hand-sewn end-to-end anastomosis. The segment of the small bowel and the blind ending diverticulum were sent for pathological examination. This is the diverticulum, which just as Dr. Nasir has rightly mentioned, Merkel's diverticulum, this is the region of the inflammation and scarring. And you can see it jutting out from this aspect of the small intestine. And the final diagnosis, ladies and gentlemen, is Merkel's diverticulum. So with this, I want to sincerely appreciate once again the Faculty of Surgery, most essentially Dr. Dr. Jimoh, for doing a very good job. Let me sound it here once again that Dr. Dr. Jimoh never had any access to this document that I just read. What we normally do is just to give him the case notes to go and do the work. And as we can see that he has done a very good job at unraveling this particular case. I'm going to send the article to the doctor's assembly page for anyone who would like to read, and also you are going to find the references on that particular article. So I think I can see someone raise his hand, Dr. Let me see. Okay, Dr. Luwenga, please, you can unmute your mic. Okay, 2 hands now. Please, you can unmute. Go ahead, please.
Yes, thank you. Please, I just have a question.
Go ahead.
Why you have told us it's better the H2 receptor antagonists are very good at retaining the radioisotope used for the scan. Can a PPI be used too?
A PPI can also be used, but the commonly used medication, we call it a pre-medication, is the H2 antagonist, but you can use a PPI too. Does that answer your question?
Yes, thank you.
Okay. You're welcome, sir. I have another hand. Let me check. Okay, Dr. Abdulsalam, please, you can unmute your mic.
Okay, good evening and thank you for the presentation. I just have like a question and like 2 questions. Yeah. So firstly, I want to ask about the abdominal ultrasound. Yes. From the presentation, I think what gave them like a final point that ruled out intussusception from the paper. They said that since the abdominal ultrasound didn't pick it, like they were sure that, oh, it's not intussusception. So my question goes thus, you know, at times for some of them, it's the stuff telescopes and releases itself. So my question is that if, for example, it is when the intestines have loosened up a bit and you do your abdominal scan during that time, I don't know, is it likely going to, are you still going to be very, very sure about it? Then 2, about contrast enema. I think some people usually, I've seen it somewhere that you can also use that one to diagnose intussusception. But in this case, I don't know, maybe because of the bleeding, maybe that's why it was not tried. Thank you. Hello?
Yes, I can hear you. Thank you very much.
Yeah.
Thank you very much. And I think that question should be for me, or I should, let me allow, is Dr. Nasir still there? Because it's more like a radiology related questions. But let me just quickly say, if Dr. Nasir has anything to say, please I will allow him to unmute now. But if peradventure, you will note in the case notes that the time that the scan was done was specifically stated as 35 minutes. So when the patient came in, the person has something in mind for stating that time limit. Just like Dr. Nasir has rightly observed, that it's possible within that particular 35 minutes that if it was an intussusception, it might have reduced result by itself. Now, on ultrasound, we might not be able to say specifically that this thing has been an intussusception before that just resolved. The only thing you might see, because of the the mechanical mechanism that is involved in intussusception, we might see some some bowel warts thickening. The bowel warts might be thickened, and there might be some reduced peristalsis in the region where that particular lesion has been suspected to be. But it is not a specific finding, because you can see it in other conditions too. Like if a patient is having enteritis, for example, you can have similar finding in that part. So you cannot say specifically, unless you are Babalawo, that this person, what I'm saying, this person had intussusception before. That's why I'm seeing what I'm saying. So it is not, you cannot say it. That is my own understanding of what. So if it has resolved, it has resolved. You cannot say that it's likely intussusception. The rest is left to your clinical acumen to decide that what happened before. And Dr. Nasir has clearly stated it, that you can, from clinical, the way the patient presented clinically, you can say, okay, since this thing might have resolved, what the patient came with was an intussusception, but scan might not be able to tell you. Now, the barium study, yes, we use it, but because of the torrential bleeding, just as we have also likely said, it's going to be a very messy procedure. And then for a child of 6 months old, we are also very careful with that kind of procedure. There was history of constipation in this particular patient. One of the side effects, one of the aftermaths of a barium enema, it can lead to constipation, because after some time, the contrast that you use forms something like a solid that makes it very difficult for the patient to even pass through. So that's why we advise them after the procedure to take plenty of water. So you don't want to add more complications just because you are looking for it. Just like putting a bomb inside your house because you want to kill a rat. So, Dr. Nasir, do you have anything to add? You can unmute your mic if you have anything that you want to add to the.
Thank you, Dr. Thank you. So for the question, I think I shared the same sentiment as before. For intussusception, apart from ultrasonic diagnosis, the clinical picture of intussusception is not likely to come as the index is presented. The degree of bleeding, the kind of bleeding you have in intussusception, is such that doesn't cause hemodynamic instability. So by and large, the clinical picture of this patient is not in keeping with intussusception. So for the barium studies, I shared the same sentiment with the ARIMI also. Besides what they also said, let us also know for the barium study, what it will just do is to outline the gastrointestinal tract. However, it won't show the source of bleeding. So that is why barium study is not always pushed forward as a diagnostic investigation of choice, because it will not show the source of bleeding, if any. The bleeding could affect from other parts of the gastrointestinal system. So that's why that test is not always pushed forward as a first-line test to diagnose naked diverticulum. And it has also been said that for barium study, and if one intends to do the Merkel scan, the better one should not do the barium study first, because it will obstruct visualization of the tract. So that's all I have to say on the question. Thank you.
Thank you very much. I think with that, we are going to be drawing the curtain on this month's edition of Virtual Assembly. And let me sincerely appreciate all the honorable members of Doctors Assembly for always coming on whenever we're having this meeting. Just as I used to say, it has been a source of motivation for me and all other stakeholders that are planning this in the back room. I also want to use this opportunity to congratulate once again our honorable members who were successful at the just concluded West African College of Surgeon, West African College of Physician Part 1 examination. And we wish them all the best going forward, more grace to their elbows. November, it's the assembly month. That is when we mark the birthday of Doctors Assembly. The Doctors Assembly started on the 11th of November 2014, and we have been waxing stronger and stronger over time. And by that time, we are going to come with a special edition of maybe a virtual assembly or something very special for our members. And I would like to use this opportunity to wish all of us a happy night rest. Till other time, it's a bye-bye from this end. Good night, everyone.